Chapter 14 in RAU, Respiratory Care, Pharmacology. Today we'll be speaking about antimicrobial agents. We need to identify the pathogen before we can do antibiotic therapy. The simplest and most common preparation is the Gram stain. This stain designates a bacteria into two major classes, gram-positive, which you see in the picture in purple, or gram-negative, which will stain pink or red. The bacterial stain differently depending on their structural components of their cell walls. These structural components also affect their susceptibility to different antimicrobials. The Gram stain also distinguishes bacteria from one another by what they look like, their shape or morphology. Other bacteria, such as Mycobacterium tuberculosis, need the use of an acid-fast stain to penetrate their waxy cell-like walls. Mycobacteria generally require 10 to 14 days for growth, but it could take as long as 6 weeks, which makes the acid-fast stain vital for rapid diagnosis of TB. Certain fungi can quickly be identified using India ink and potassium hydroxide, KOH preparations. Urinary antigen tests are routinely performed for rapid identification of things like Streptococcus pneumoniae and Legionella pneumoniae. And rapid antigen tests for influenza allow detection as well as to distinguish whether it's influenza A or B. Collecting a clean specimen is important. Specimens that are commonly collected include blood, urine, sputum, cerebral spinal fluid, pleural fluid, synovial fluid, peritoneal fluid, and stool. Susceptibility testing and resistance. The susceptibility of an organism to an antimicrobial is quantified as the minimal inhibitory concentration, or MIC, and the minimal bactericidal concentration, MBC. The science of understanding the optimal effect of an antimicrobial is a function of its concentration to the MIC against the microorganism known as pharmacodynamics. We'll talk a little more about pharmacodynamics later. Pictured here is a susceptibility testing plate. Susceptibility test results can usually be attained within 24 hours, and several methods are used to determine the susceptibility of an isolated pathogen. The Kirby-Bauer disc diffusion test involves the use of which is pictured here, antibiotic impregnated discs that are placed on an agar plate and heavily inoculated with the isolated bacteria. If the organism is susceptible to the antibiotic, a clear zone of inhibition, no growth of the organism, develops around the disc. Published breakpoints for the diameter of the clear zones are used to determine whether the organism is susceptible or resistant to the antimicrobial agent. However, they do not provide specific data on the concentration needed to kill or inhibit the growth of the organism. Another test, the E-strip test or elliptical test. The E-strip test is placed on an agar plate heavily inoculated with an isolated organism. The strip creates an antimicrobial gradient which allows a clear elliptical zone of inhibition. This method allows doctors to determine the minimal inhibitory concentration needed, or MIC. MIC is defined as the least concentration of an antimicrobial that prevents visible growth. Other methods include inoculation of the organism into serial dilutions of an antimicrobial agar, or more commonly in broth culture media. Automated systems such as Vitek, Microscan, and BD Phoenix take advantage of broth microdilutions to provide efficient and rapid susceptibility tests. What are some of the things that antibiotic therapy is determined by? Host factors is one of those things. The outcome of my antimicrobial therapy depends on a host factor's susceptibility or resistance to the antimicrobial and pharmacodynamics. Other important factors include immune status, travel history, recent exposure to antimicrobials in the last 3 months, as well as what drugs they're taking and what disease states the patient is in. In addition, drug factors such as available dosage forms, ease of administration, pharmacokinetic and pharmacodynamic properties, tissue penetration, and drug toxicities and cost influence the choice of a specific antibiotic. Let's look at host factors. Host factors play a significant role in the selection of optimal antibiotic therapies. Consideration must be given to factors such as history of allergy or intolerance, age, organ dysfunction, pregnancy and lactation, and site of the infection. Age can affect liver and kidney function and the stomach pH. And in the case of a pregnant person, we need to understand if the antibiotic harms the unborn child. Pharmacodynamics. Pharmacodynamics refers to the science of understanding the optimal effect of a drug as a function of its concentration and the in vitro activity, or MIC, against an organism. The pharmacodynamic properties of an antimicrobial are measured in vitro by using time-kill studies. Time-kill studies are tests that are not performed in most microbiology labs, but instead are done in research facilities that study the optimal dosages of antimicrobial agents. The studies measure the rate and extent of microorganism killing over time when exposed to varying concentrations of antimicrobial drug. If the microbial kill rate increases proportionately with the drug concentration, the antimicrobial is said to have a concentration-dependent effect. If the microbial kill rate is influenced by the time of drug concentration above the MIC, the antimicrobial is defined as time-dependent or concentration-independent. Another pharmacodynamic phenomenon exhibited by antimicrobials is known as the post-antibiotic effect, or PAE. The PAE is the sustained suppression of bacterial growth even after the concentration of the antibiotic declines below detectable levels. The length of the PAE varies by the type of organism and the drug. Generally, time-dependent drugs, such as the B-lactams and vancomycin, have short PAEs, whereas concentration-dependent drugs, such as the aminoglycosides, have a longer PAE. Antimicrobial combinations. Empiric regimes often cover a broad spectrum of organisms, which occasionally require the use of 2 or more classes of antimicrobials. Ideally, the regime should be narrowed after the specific organism has been isolated and susceptibilities are determined. Certain infections are polymicrobial, and in certain settings, the use of antimicrobial combinations is justified, like when treating TB. Even things like infections in patients with cystic fibrosis may need combination therapy. Pseudomonas pneumonia is often colonized with a resistant species, and so combinations of B-lactams and aminoglycosides have been shown to curb the development of resistance and to improve outcomes. Remember that you may need to cover a broad spectrum of organisms. The regime may need to be narrowed once the organism is identified. And certain infections, as we've discussed, can be polymicrobial. Drugs can be synergistic, work together, or antagonistic, work against each other. Monitoring response to therapy. Monitoring response to therapy involves laboratory parameters and clinical assessment. Clinical assessment is key. Treatment failure can manifest as continued fever spikes, elevated white blood cell count, repeated positive blood cultures, and the non-resolution of symptoms. Let's talk about specific antibiotics. The B-lactams are a large class of antibiotics that include penicillin, cephalosporin, carbapenems, and monobactrams. The penicillins work by inhibiting cell wall synthesis. They are bactericidal and activate endogenous autolytic system in bacteria. They can act synergistically with aminoglycosides. Natural penicillins, like penicillin G, is a parent compound of this class. Natural penicillins are made from bread mold and are effective primarily against gram-positive bacilli and anaerobes. Penicillin G is the drug of choice for the treatment of primary and secondary syphilis, along with pharyngitis caused by group A streptococcus. In an attempt to penicillin-resistant penicillins, in an attempt to overcome the emergence of penicillinase-producing staphylococci and semi-synthetic penicillinase-resistant antibiotics were developed. The agents are commonly referred to as anti-staphylococci agents because of their excellent activity against Staph aureus. Methicillin is one of the first agents in this class of antibiotics, followed closely by oxacillin, neflicillin, cloxacillin, and dicloxacillin. Chemical modification of penicillin by the addition of an acetyl side chain prevents hydrolysis of these agents in the presence of penicillinase. This class has activity against gram-positive cocci like staphylococci and streptococci. and it's routinely used in skin and soft tissue infections. Ampicillins. Aminosillins were the first penicillin class developed that were considered clinically active against gram-negative bacteria like E. coli and H. influenza. Ampicillin and amoxicillin are primary antibiotics in this class. Carboxypenicillins. With the emergence of more resistant gram-negative bacilli, penicillins with increased gram-negative activity were needed. Carbenicillin was the first penicillin to be active against Pseudomonas aeruginosa. It is also active against most members of Enterobacter family, including E. coli, Enterobacter proteus, and Serratia. Subsequent modification of carbenicillin resulted in ticaricillin, which has even greater in vitro activity against Pseudomonas aeruginosa and the Enterobacter family, including Klebsiella. Neither of these agents is considered to have appreciable activity against gram-positive organisms, like staph and strep. These agents are mainly given in an IV form because the serum concentrations cannot be achieved with oral dosing. Uridocillins. Although carbenicillin and ticaricillin provided increased gram-negative coverage, antimicrobial agents with enhanced pseudomonal activity were still needed. The uridopenicillins were developed to fill this need. Piperacillin is a penicillin antibiotic with enhanced gram-negative activity against Pseudomonas aeruginosa, with fewer adverse side effects than the carboxypenicillins. These are especially good in the treatment of pneumonia, bacteremia, UTIs, osteomyelitis, and soft tissue infection. B-lactam and B-lactamase inhibitor combinations. Certain bacteria have the ability to produce enzymes, the B-lactamases, that destroy the activity of penicillin by disrupting the B-lactam structure. B-lactamase inhibitors were developed to overcome this form of resistance, and combination B-lactams and B-lactamase inhibitors have a large spectrum of activity, making them particularly useful in polymicrobial infections. At present, there are 3 B-lactamase inhibitors that are approved for combination with penicillin. That is the clavulanic acid, sulbactam, and tazobactam. B-lactamase inhibitors enhance the activity of B-lactams against lactamase-producing strains of Pseudomonas aeruginosa, S. aureus, Monaxella, E. coli, H. influenza, Klebsiella, and Bacteroides species. Adverse reactions and precautions with antibiotic therapy. The most common adverse reaction to penicillin is hypersensitivity. Approximately 3 to 10% of the population is allergic to penicillin, and reactions can vary from a mild rash, as pictured here, to life-threatening anaphylaxis where they stop breathing. Patients allergic to a penicillin could be allergic to all classes, including cephalosporins and carbapentins. In addition to allergic reactions, hematologic reactions such as thrombocytopenia and increased bleeding times have been reported. Gastrointestinal disturbances like nausea, vomiting, and diarrhea are common with oral dosing of penicillins, especially ampicillin. And nephritis has occurred commonly with methicillin. Also, Patients with an underlying seizure disorder and patients with renal insufficiency are at greater risk for developing this complication. Let's talk about the cephalosporins. Cephalosporins have been loosely grouped into generations on the basis of their spectrum of activity. At present, there are 5 generations or classes of cephalosporins. The way cephalosporins work is they inhibit bacterial cell wall synthesis, and they are considered bactericidal. First-generation cephalosporins are used in a wide variety of against a wide variety of gram-positive organisms. Second-generation cephalosporins are used against gram-positive and some gram-negative organisms. The third generation of cephalosporins are active against most gram-negative organisms. The fourth generation of cephalosporins extend the gram-positive and gram-negative coverage. And the latest or fifth generation of cephalosporins, of which ceftaroline is the first and only member, has a broad gram-negative and gram-positive use, as well as activity against MRSA. However, it doesn't work well against Pseudomonas aeruginosa. Adverse reactions with cephalosporins include 1 to 3% of the population with hypersensitivity, minor gastrointestinal complaints like nausea and vomiting, and hypoprothrombocytopenia, especially those with an MTT side chain. You can see flushing, nausea, thirst, palpitations, chest pain, vertigo, and in some cases, death from anaphylaxis. They quit breathing. Carbapenems. Carbapenems work similarly to other beta-lactams. They inhibit cell wall synthesis and are considered bactericidal. Clinical uses for the carbapenems include Pseudomonas aeruginosa, gram-negative bacilli, most anaerobes, gram-positive organisms, and MSSA and streptococcal species. It should be noted that ertapenem is not good against Pseudomonas aeruginosa. Adverse reactions that are seen are there is a low amount of adverse reactions. They're generally well tolerated. The occurrence of seizures has been reported with these antibiotics, more frequently with imipenem than with meropenem, doripenem, or ertapenem. Seizures are most commonly seen in patients with decreased renal function and underlying seizure disorder. Monobactrams. Aztreonam is a synthetic monocyclic beta-lactam antibiotic. It is the only commercially available agent belonging to this class of antibiotics. The mechanism of action is similar to other beta-lactams in that it inhibits cell wall activity, and it also exhibits bactericidal activity. Atrenum is approved by the U.S. Food and Drug Administration as an aerosol in the treatment of Pseudomonas aeruginosa infection in patients with cystic fibrosis. There are few adverse reactions. It's well tolerated. Rarely there is rash or anaphylaxis to this particular drug. The aminoglycosides. Streptomycin was discovered in 1943 and was the first antimicrobial agent available for the treatment of tuberculosis. Numerous other aminoglycosides have been developed since and include gentamicin, tobramycin, or Toby, netamycin, amikacin, These agents are used for treating gram-negative infections, including infections caused by Pseudomonas aeruginosa. These antimicrobials have poor gastrointestinal absorption and require IV administration. Aminoglycosides work by inhibiting RNA translation, destabilizing the cell wall, and are considered bactericidal. They're used in nosocomial gram-negative infections, or VAP. Some adverse reactions of the aminoglycosides include toxicity of the kidneys, toxicity to hearing, and neuromuscular blockade with a rapid high-dose use. Let's talk about the tetracyclines. Tetracyclines inhibit the attachment of RNA to its acceptor site and are considered bacteriostatic in that they inactivate the bacteria, but they do not kill it. They're used in gram-positive and gram-negative microorganisms. Tetracyclines are considered broad spectrum, and they are effective against rickettsia, chlamydia, mycoplasmas, spirochetes, protozoa, and mycobacteria. The most commonly used agent in this class is doxycycline because it can be administered twice a day and is relatively inexpensive. Other available tetracyclines include minocycline and tetracycline. The agents are available in both oral and parenteral or IV formulas. Rickets. Adverse effects with tetracyclines include nausea, vomiting, and diarrhea, the inhibition of bone growth when used in young children, and calcium, magnesium, and iron absorption, inhibition of iron. Let's talk for a minute about tigecycline. Tigecycline, a glycocycline antibiotic, is similar in chemical structure to tetracycline antibiotics because of substitution of a center 4-ring carbocyclic nucleus. Tigecycline has a greater spectrum of antibiotic activity than tetracyclines. It's good against most gram-positive bacteria, including Pseudomonas pneumoniae, Enterococcus, including vancomycin-resistant strains, Staphylococci, MSSA, and MRSA. Tigecycline also has been shown to be active against most gram-negative bacteria, including H. influenza, M. cardialis, and most members of the Enterobacter family. It inhibits protein synthesis even against most tetracycline-resistant organisms. It's bacteriostatic and bactericidal against Pseudomonas pneumoniae. Its used in complicated skin and intra-abdominal infections. And adverse reactions and precautions are mostly minor, with gastro nausea, vomiting, diarrhea, and abdominal. Macrolides. Macrolides work by inducing dislocation of the transfer RNA from the ribosome during elongation phase. They are considered bacteriostatic. They're used in atypical and community-acquired pneumonia and chlamydia infections in pregnant women. Adverse reactions and precautions include nausea, vomiting, and diarrhea, and they may increase the concentration of drugs like theophylline, warfarin, and triazolam. Telithromycin is generally better tolerated than erythromycin. Most common adverse reactions include gastrointestinal complaints such as nausea, vomiting, abdominal cramps, and diarrhea. The use of IV erythromycin has also led to ventricular tachycardia and QT interval prolongation. Visual disturbances are also common. Let's talk about Levaquin. Levaquin is a commonly used antibiotic in patients with pulmonary disorders that you're likely to see, like COPD. It's a semi-synthetic group of antibiotics structurally related to quinolone, one of the byproducts of chloroquine synthesis. They are widely distributed in most of the body fluids and tissues, achieving a high respiratory tract concentration. They're mainly eliminated through the kidneys. Cipro, Levaquin, Oflox, Baxdela, and Avlox are all quinolones. They inhibit DNA synthesis and are considered bactericidal. They're great for gastrointestinal tract infections too, and skin infections, as well as pneumonia in COPDers. They are one of the safest antimicrobial classes, with mostly gastrointestinal side effects like nausea, vomiting, and diarrhea. Chloramphenicol is a broad-spectrum antibiotic. It's good against gram-negative, gram-positive, and anaerobic bacteria. It's bacteriostatic, and its clinical uses include gastroenteritis, sepsis, salmonella infection, and rickettsial diseases like rickets. There are some adverse reactions and precautions. It can suppress the bone marrow, and it can cause blindness. Colistin. Colistin is usually given by inhalation. It's a surface active, it's been around forever. It's used in CF, and it's surface and in lung transplant patient. It's surface active and incorporates into cell membranes, causing disruption of bacteria. Its clinical uses are systemic infections by gram-negative bacteria, as well as, where we'll usually see it, nebulized against multi-drug resistant Pseudomonas aeruginosa and Acinetobacter in CF patients and in transplant patients. Adverse reactions and precautions include damage to the kidneys, and dose-dependent neuromuscular blockade. Daptomycin. They're not really sure, but they think it disrupts the cytoplasmic membrane of bacteria. Its clinical uses include complicated skin infections by gram-positive bacteria, Staph aureus infection, and Staph aureus bacteremia. It can elevate creatinine levels and cause rhabdomyolysis. TMP-SMX, or trimethoprim sulfamethoxazole. The mechanism of action is that this particular antibiotic blocks enzymes needed for bacteria to produce folic acid. It is bacteriostatic, not bactericidal. We use it in pneumocystis carinii pneumonia to prevent against it, acute bronchitis, acute ear infections, and Shingella infections. Shingles. It displays good activity against MRSA. However, there are some precautions and adverse reactions. The most common adverse reactions include nausea, vomiting, diarrhea, and hypersensitivity. There can be neutropenia, thrombocytopenia, hemolytic anemia, jaundice, hepatic necrosis or liver necrosis, and drug-induced lupus, all due to sulfamethoxazole. Clindamycin. Clindamycin inhibits protein synthesis and is bacteriostatic. It is active against both gram-positive and anaerobic bacteria. It has a fairly significant activity against MRSA. However, it can cause nausea, vomiting, and diarrhea. It's commonly given in dental procedures when the person can't take amoxicillin. Metronidazolone. Its mechanism of action, or how it works, is unknown. It is bactericidal. It kills most anaerobic pathogens. It's used in anaerobic infections like Trichomonas and Clostridium. Adverse reactions include a metallic taste in the mouth, nausea, and vomiting. Long-term use can lead to peripheral neuropathy. Vancomycin. You're likely to see this used in the ICU. It prevents formation of the rigid cell wall. It's bactericidal against most gram-positive organism and bacteriostatic against enterococci. We use it against MRSA and against C. difficile Clostridium. Adverse reactions include red man syndrome, toxicity to the ears and to the kidneys. Telavancin, delbavancin, and ortavancin. These work by preventing the formation of the rigid cell wall in bacteria. They have a lymphocytic side chain that contributes to potency over vancomycin. Clinically, they're used in cases of MRSA as well as VRE, VISA, and VRSA. They're also used in complicated skin infections. Adverse reactions include headache, nausea, Quinupristin and delfopristin are streptogramins that act synergistically when used together. This is in the product Sinerside. These agents are active against gram-positive bacteria and are used primarily to treat infections caused by VREF. They work by blocking peptide bond formation and distorting ribosomes to enhance the binding of the quinupristin. The ribosome-bound quinupristin inhibits the binding of amino acyl transfer RNA to inhibit protein synthesis. Adverse reactions include that they're only available in an IV formation and must be administered through a central line. It limits how they can be used. Peripheral administration is associated with a high incidence of thrombophlebitis. Linezolid. The antibiotic linezolid belongs to a novel class of antibiotics known as oxazolinones. Linezolid is similar in that it is active against gram-positive bacteria and is approved for treatment of severe life-threatening VREF infections. In contrast to vancomycin, it is available for an oral formulation and is completely absorbed from the GI tract. Antimicrobacterials. Tuberculosis has received heightened attention lately because of the increase in cases attributed to the HIV epidemic. Each year, millions of individuals are exposed to TB, many through casual contact. More than 1/3 of the world's population has contracted tuberculosis. The U.S. Centers for Disease Control make annual recommendations for the prevention and treatment of TB infection. Nosocomial transmission can be prevented by placing patients with suspected or confirmed tuberculosis in respiratory isolation. INH works by inhibiting cell wall synthesis and is bactericidal. Adverse reactions and precautions are that it can be toxic to the liver and the kidneys. Nausea, loss of appetite, and abdominal pain are very common. Rifampin and rifabutin may also be part of a combination regime to treat TB. These inhibit RNase polymerase and are bactericidal against actively dividing bacteria. However, adverse reactions are that they may cause bodily fluids, especially rifampin may cause bodily fluids to turn an orange color. There may be fevers, chills, and nausea, and it can be toxic to the liver. Pyrazinamide is another one used. Its mechanism of action is unknown and it's bactericidal. Adverse reactions include nausea and vomiting and hepatotoxicity. Ethambutol decreases the synthesis of cell wall polysaccharides. It's bacteriostatic and includes optic neuropathy. Streptomycin. Streptomycin has a similar action to other aminoglycosides. It can be toxic to the kidneys and to hearing. The number of antifungals is increasing dramatically. Amphotericin B and nystatin work by increasing the permeability of the cell membrane. Clinical uses are in cases of Aspergillus infection, blastomycosis, histoplasmosis, coccidiogemycosis or valley fever, and cryptococcus. Adverse reactions and precautions include flushing, fever, and chills, which are related to the infusion, and renal impairment. Azoles reduces ergosterol production and has a fungistatic effect. It's good in uses of candidiasis and has adverse reactions of anorexia, nausea, and vomiting. A candidiasis infection. It's like having a sunburn on the tongue. Echinocandis works by inhibiting fungal cell wall synthesis. It's fungicidal or fungistatic depending on the isolate. Clinical uses are in fungal infections of Candida and Aspergillus. Adverse reactions include fever, rash, flushing, and thrombophlebitis at the site. Flucytosine inhibits fungal RNA formation, is fungistatic, and used clinically in Candida, Cryptococcus, and Aspergillus infections. Adverse reactions include bone marrow suppression. Let's talk for a bit about antiviral agents. Some of the antiviral agents include acyclovir and valacyclovir. They work by terminating the viral replication. They're used in herpes virus, Epstein-Barr syndrome, cytomeglia or CMV infections, which you may see in CF patients and in lung transplant patients. They also work in varicella zoster or VZV infection. However, adverse reactions include neuropathy, burning, and irritation if they are used topically. Pencyclovir and famciclovir interfere with the viral DNA synthesis and replication. Their clinical uses include genital herpes simplex and VZV. Adverse reactions and precautions are occasional nausea, vomiting, diarrhea, and headache, and rarely neutropenia. Ganciclovir and vegnacyclovir terminate viral DNA synthesis and replication. They're used in HSV, VZV, and cytomegalovirus. Adverse reactions include bone marrow suppression, headache, nausea, rash, fever, and liver transaminase elevation. Cidofovir inhibits viral replication. It's used in the herpes virus and cytomegalovirus. It has dose-dependent nephrotoxicity and can result in a fever, rash. Foscarnet blocks viral polyesterase or inhibits viral replication. Its clinical uses is in herpes virus and hepatitis B, influenza, both influenza A and B. There is some neurotoxicity in about a quarter of the patients that use it. Fever, nausea, vomiting, headache, diarrhea, and electrolyte imbalance are also adverse antiviral. Amantadine and rimantadine inhibit viral replication and assembly. They also may inhibit the uncoating of the influenza virus. They're active against influenza A virus. They're well tolerated. However, they can result in tremor, insomnia, lightheadedness, seizure, cardiac dysrhythmias, and agitation. Oselivir and zanavir are neuraminidase inhibitors. They inhibit influenza A and B neuraminidase, and they prevent the virus from leaving the host cells. They're used to treat influenza A and B infection. However, nausea and vomiting may occur in the first 2 days of therapy. Biologics. Biologics are substances that are synthesized from living systems. Monoclonal antibodies are a category of biologics. They are currently being utilized to treat immune disorders, neoplasms, cirrhosis, psoriasis, multiple sclerosis, and rheumatoid arthritis. They are under development to target infectious pathogens. Rexibacumab and obinutuzumab work by human immunoglobulin monoclonal antibodies that bind and neutralize the protective antigen of the Bacillus anthrax. They're used for adult and pediatric post-exposure treatment of anthrax, inhaled anthrax in conjunction with a recommended antimicrobial agent. They are also approved for inhalation anthrax pre-exposure prophylaxis when alternative therapies are inappropriate or not available. Adverse reactions include a risk of hypersensitivity reaction. A lot of times they'll pre-medicate with diphenhydramine. Common adverse reactions include headache, upper respiratory tract infection, and cough. Respiratory care assessment of antibiotic therapy includes, before treatment, assessment of the effectiveness of the drug therapy on the basis of clinical indicators. During treatment and short-term treatment, consider susceptibility testing and make sure that you do a thorough patient assessment. In long-term use, monitor the response to the anti-infective agent and consider a combination of agents, especially in the case of things like TB. General contraindications include that they should not be used unless a specific pathogen is known or suspected. Thank you for your time and attention. This is the end.